mode, and
Okay.
then we can dive into it.
You're seeing the slideshow right now, right?
Yep, yes, we can see it.
Okay, great. Okay.
Well, so
Oh, and
I'm
go
not
ahead.
seeing it. I'm not seeing it in presenter mode. It's just so I think you might have to go to hit from beginning.
Yeah, I did.
Okay, we're just seeing the app, the PowerPoint app. We're not seeing it in presentation mode, which is
Okay, hold
okay.
on.
We can,
I thought I was in presenter mode. Let's see. It says it's clicked to use presenter mode.
maybe hit escape and try again.
To stop sharing and try again.
Yeah.
Stop sharing.
So when you share, did you hit share PowerPoint or the whole screen?
I did a window.
Okay, let's try that again. So share.
Okay. Share. And now I'm not seeing the option to share the window. Okay, so it's letting me do the whole entire screen. So it says application. If I click that, will I be able to just do the PowerPoint?
Yeah, I think so. I
Window.
think you should be able to select PowerPoint.
And from current slide. How's that?
We're still only seeing it as the application, so it's not the full screen, but that would be okay if escape from, if you're seeing it in full screen mode right now, just get out of that and then just go through it slide by slide because it's okay if we can see it as it is right now.
Oh, okay. I see what's happening. So you're seeing, you're not seeing the slideshow. You're seeing the individual slides.
Right. We're seeing the full PowerPoint application, but it's okay.
It's okay. Okay.
Yeah, we can just do it this way. It's okay. We don't need to
Okay, great.
think. Okay, so I'm just gonna do the quick housekeeping and then we can get started. So let's just bear with me. All right. Thank you so much everyone for joining us for today's webinar, Forward Facing Professional Resilience. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I will be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar in a few different ways. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Dr. David White, will take questions throughout the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1.5 PCB and or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificate to be available on your MyIRETA profile because we will have to cross-check attendance records with WebEx following the webinar. After the webinar, you will receive a follow-up email. The email will include a link to an evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Dr. David White has been helping professionals for over 50 years, working in vocational rehabilitation, secondary schools, violence prevention, criminal justice, and addiction. He lives in Loganville, Georgia, where he owns Entrainment Counseling, LLC, which provides counseling or coaching for addiction, trauma, anxiety, and grief and loss. His primary methodologies are forward-facing Brainspotting, and HeartMath, and Existential Counseling. Okay, Dr. White, I will pass it over to you. And just a reminder, just try to keep it in the app rather than the going to the full screen because we can only see the app.
Okay, great. Good afternoon or morning or evening, wherever you are. I'm delighted to be here with you to have this opportunity to share this information about forward-facing professional resilience. So let me get right into it because our time is already a little bit late. My technology was not cooperating very well. So forward-facing professional resilience is designed to address a particular problem, and that problem is compassion fatigue. Compassion fatigue is described as a condition that occurs when helping professionals absorb the emotional and psychological distress of those they help, leading to trauma-like symptoms. Compassion fatigue the term was coined by Charles Figley back in 1995. Figley is a pioneer in compassion fatigue and trauma psychology. He coined the term, and in his description, it's the emotional and physical exhaustion experienced by those helping survivors, helping trauma survivors. So there are people like therapists, first responders, healthcare workers, mental health professionals, teachers, pastors, caregivers, volunteers, and that type of individual. He developed from this the compassion fatigue resilience model, and it emphasizes how real or perceived distress of another human being in turn distresses us and the process by which we become dysregulated. Dr. Figley was the dissertation advisor for my mentor, Dr. Eric Gentry, who's the developer of forward-facing professional resilience. So here's the thing. Once you've decided that there's such a thing as compassion fatigue, how do you go about defining and measuring its impact and whether or not it's present? So Dr. Beth Hudnall-Sam, a University of Idaho author and developer, came up with an instrument called the Professional Quality of Life Scale. And it is the definitive instrument that is used to describe whether a person has compassion fatigue or not. It has 3 subscales: compassion satisfaction, secondary traumatic stress, and burnout. The first issue or first version of it was issued in 1998, and it was redesigned in 2009. And it's an instrument that has high psychometric qualities, meaning it's very reliable and the validity is pretty high as well. So professional quality of life, what are we looking at? Compassion satisfaction talks about the resilience and work satisfaction. So when you're at work, how resilient are you? How well are you able to bounce back? And how satisfied are you by what you're doing at work? Burnout talks about the level of negative effect that the work environment has on you, whereas the secondary traumatic stress scale looks at the negative effects caused by the actually doing the work. So it's the interaction between you and whoever you're working with, and what's the level of suffering or traumatization that you receive from working with those individuals. When you take the test, I want to caution you that it's normed against people who have compassion fatigue. So if you are high on that scale, you're high compared to people who have the disability or who have the distress. It's not normed against the ordinary public. So just because you're doing well in this, you're doing well compared to people who have compassion fatigue. So keep that in mind if and when you actually do take this instrument. Compassion fatigue, I love this quote. Viktor Frankl, who some of you may be aware of, he wrote the book Man's Search for Meaning. and developed something called logotherapy. And Dr. Frankl says that which is to give light must endure burning. So the issue is not whether or not you're going to be burning somewhat, but whether or not you're going to be suffering as you're doing your work. So when you're doing the work of a helper, it is understood that some of it is going to be stressful. It is understood that you're going to have to dig down deep sometimes and go to places where you might ordinarily want to go. The issue is when you go to those places, can you come back and not be suffering and hurt because of the work that you're doing? So Viktor Frankl's quote, I think, is very appropriate to look at what's happening with people who are in helping professions. Now, how do people become traumatized or end up with secondary traumatic stress? So traumatogenesis is like this. You have a neutral stimulus. So this young lady is hugging her dog. She likes dogs. Dogs is not a problem for her. So it's a neutral thing when she's exposed to dogs. Now, you take that neutral stimulus and you pair it with a charged exposure. And the charged exposure in this case is a dog that is angry and looks like he's in attack mode. You pair that with the non-neutral stimulus, and you end up with a conditioned response. And that conditioned response leads to stress or trauma. So this response could be fear, it could be anger, it could be frustration, whatever it is. But the point is, trauma comes about when you have a neutral stimulus and you compare it with a charged event, something that gives you an emotional reaction. And it then leads to you having a conditioned response to that thing that did not used to bother you. This is classical Pavlovian conditioning. If any of you are familiar with Ivan Pavlov and the Russian gentleman who basically discovered classical conditioning. And this is what classical conditioning is about. You take something that has no charge for you, you pair it with something that does have a charge, and then see what happens when you put the thing that did not originally have a charge in the situation where it can receive some input. So in this case, the woman now, after she's experienced this traumatic event with the dog, now it's not just about that one dog that traumatized her. If you expose her to any dog, and in this case, you see this little dog here on the screen, and she's imagined that it's the same situation as when she was attacked or threatened by this big dog, so that the conditioned response comes up in any situation that is similar to the one that caused you the distress. This response, the conditioned response, gets stored as what's called implicit memory. Let me take a second and talk about that. In your brain, memory is normally supposed to be stored in a place called your hippocampus. That's where procedural memory gets logged. So if I were to ask you, what did you do this morning before you came on this webinar? You would have a narrative that goes with that. You could tell me you woke up, you did your normal morning routine, you went to work, and whatever the situation is, you would be able to explain that to me because it's in the proper place in your memory and you have access to it. Implicit memory does not get stored in the hippocampus. It gets stored in other parts of the brain and in the nervous system. And so that anytime you're coming up on a situation that is similar to the thing that caused you the distress, you can become triggered. And we'll talk about that a little bit later. So what happens when you have traumagenesis or secondary traumatic stress? Because as you're talking to people and doing your work, you can kind of end up with a narrow lens that you start to believe that people are this particular way that your clients are, because that's what you're exposed to all the time. And if you're not mindful of what's going on with you and the client, you can become distressed by listening to the client's story. That's how we end up in a situation where you end up with compassion fatigue, which, as I said, is the combination of secondary traumatic stress or vicarious trauma and burnout. And we're going to look at each of those in a little bit. So when you have secondary traumatic stress, these are the symptoms that let you know that you might have you're starting to develop secondary traumatic stress. So you have intrusion. Intrusion of things like nightmares, flashbacks of the client's material. So you listen to the client and you might be thinking or sitting around, and the thoughts about what's happening with these clients just come in your mind, or you find yourself dreaming, having nightmares about what's going on with the client. You're worrying about work. You have an inability to separate your work from the rest of your life. So you go home and you bring the work with you. It's intruding into your activities of daily living. You're overly concerned about your clients or coworkers. They're staying on your mind. You're thinking about them. As I threw in here, you can start to have impact of secondary traumatic stress based on your interaction with your coworkers as well. Although this is focused on clients, it can also happen with some of the workers or your coworkers on the job. You end up with emotional distress after exposure to traumatic reminders. So something that reminds you of the conversation or the narrative you have with your clients starts to put you in emotional distress. You can start to notice that all of these things are events of the situation that you've dealt with your clients or the person you're helping, intruding into your activities of daily living when you don't necessarily want them to. They just pop up. Unwanted memories, physical reactivity after exposure to traumatic reminders. And at the same time, you're having an increase of the perception of threat. Not necessarily the reality, but your brain doesn't know the difference between the reality and the perception. Your nervous system is going to react the same way. So you're perceiving threats in larger amounts and in different places than you normally would. So that's part of the process of intrusion that relates to the symptoms of traumatic stress. Avoidance. Avoidance shows up in funny ways, and I didn't used to think about it this way, but procrastination is a form of avoidance. So you have dread, you have depression, you have a sense of hopelessness. You start to go into the situation of blaming. You have constricted muscles. You're starting to have problems in your relationships. You're diminishing your self-care activities. You're starting to become more isolated. You're ruminating. You're thinking about what's going on. Figley has something on this where he talks about the silencing response. And that is, as a professional caregiver, you start to not want to let the clients tell their truth because you're starting to recognize that it's bothering you, and you're trying to silence the clients so they don't speak these things that's harmful to them and is now starting to impact you as well. Continuing with that, you have alterations in cognition or mood, the inability to recall key features of traumatic events. You have overly negative thoughts and assumptions about yourself and the world, exaggerated blame of self or others for causing the trauma. It's my fault, I'm weak. Negative affect, dysthymia. Decreased interest in activities. You start the things that you used to love to do, you don't want to do them anymore. Your feelings of isolation start to creep in. You have difficulty experiencing positive effects. So most of your time now, you're thinking about negative stuff. You're not enjoying life anymore. The next category of things is arousal. So you start to have fear and anxiety. You start to exhibit compulsive behavior, obsessive thoughts, poor concentration, sleep problems with your sleep. Your weight is starting to fluctuate. You're easily irritated or angered. You're starting to show symptoms in your body. So you start to get digestive issues. You might start to develop things like hypertension and being hyper alert. You start to see disease because your immune system is impacted. You're starting to become more and more stressed. Once again, you have an increase in the perception of threat. Now, if you had been paying attention, you might notice, and those of you who work in the area might notice, that those things that I just described as symptomatic of secondary traumatic stress are identical to the criteria that we have to meet in order to be diagnosed with PTSD. So the event, in this case, the event is listening to your clients and to whatever's going on with them. Then you have your intrusive symptoms, you have your avoidance, you have alterations in mood and cognition, you have alteration in arousal and reactivity. The thing that now you have to look at is how long does it last? If it's lasting for a month or more and has clinically significant distress or impairment, and clinically significant distress or impairment you start to notice or pay attention to as you look at the things that the person is supposed to be doing in terms of their daily routine starting to become disrupted. And you want to know now that these symptoms that you're seeing can't be attributed to physiological or psychological effects. So there isn't any medical or mental health issues that already exist that would cause these things. And if you meet all those criteria, you can now diagnose a person that has secondary traumatic stress as also being in the category of having PTSD. So how do we begin to resolve secondary traumatic stress? We do it through a process called reciprocal inhibition. This is the engine of trauma resolution. So let's take a look at that. We've already looked at the person having a conditioned response. So that conditioned response now puts you in the dysregulated nervous system. You're off kilter. And that's the situation that you're in because of the trauma that existed or the scary experience that existed from you being exposed to this dog that is traumatized or coming after you, this dog that's in attack mode. What you now have to do when you're in that situation is to put yourself in a relaxed body. What happens is your nervous system is bipolar. And the autonomic nervous system cannot at the same time be in a relaxed state and an active state. So you can't have the sympathetic nervous system as well as the parasympathetic nervous system operating at the same time. Either one is off and the other is on, or vice versa. So what reciprocal inhibition is doing, it's taking the constricted muscles and bodies that exist when you are in this conditioned response state. When you're in this dysregulated state, your nervous system is activated and you're in what's called the sympathetic dominant body. You pair a relaxed muscles now with that situation. So you're activated and now you have to relax your body, relax your muscles, and that begins to move you back into the situation to where you have neutral stimulus and a regulated nervous system. What you're introducing into this equation is a relaxed body. So the intervention to start to get you back from dysregulation into regulation is to relax the muscles of your body. And as I said, it is not possible for you to have the constricted tense muscles of the sympathetic nervous system at the same time that you have relaxed muscles that we refer to your parasympathetic system. So if you look through very briefly through these pictures, you're seeing you have the conditioned response of sympathetic activation, and that immediately puts you into a threat response. And now to correct it, you look at having the conditioned response in a relaxed body, and that's going to move you back into parasympathetic activation, self-regulation, and not experiencing the secondary traumatic stress that you would normally experience if you're not starting to pay attention to this. So the very first thing you're going to do is start to recognize what's happening in your body as you are experiencing this secondary traumatic stress. And we're going to look a little bit more at that in a minute. So putting that relaxed muscle body, when the trigger comes up, is what's going to start to move you back into a neutral state so that you have a relaxed body and that you're not stressed out by seeing the dog. So once she's able to do that, she's able to start to go back to the situation where she's hugging the dogs and she's no longer traumatized by being in the presence of a dog. So resolving secondary traumatic stress is an imaginal exposure process. So you resolve secondary traumatic stress through self-regulation. That is the intentional interruption of the threat response. When you're listening to clients or when you're remembering experiences or any of those four things that shows that you're symptomatic, the thing that you have to do is recognize that you're dysregulated and start to get your nervous system back into regulation. The second thing that you have to do is build and maintain relationships. You cannot heal trauma in isolation. You need to have some people around you that you're getting support from, that you have to allow others. You need to basically have an accountability partner. Or if you don't want just one partner, you can have a small group of people that you all hold each other accountable for. If you see behaviors that are symptoms of sympathetic dominance, or you see situations where the person nervous system looks like they're off, they're behaving in ways that's starting to tell you that they might be suffering from secondary traumatic stress, you need to have a group of people, or at least one individual, that is going to call you on this, that's going to be able to talk to you about what you're saying, and you're not going to immediately get defensive, but you're going to actually hear what they have to say. So you can actually contract with with a coworker, with a family member, with a good friend, that you periodically will go and sit down and talk about what's going on with you. And that's the specific reason that you all are meeting, to look at what's happening, talk about and share what's going on with you at work, so that you have an outlet to build and maintain the relationships that will support you to stay regulated. And in that time, you're going to be sharing the narratives of the painful work experience with clients or coworkers that with a safe other. So you don't feel safe with everybody, and you shouldn't, but you should have at least one individual in your orbit that you know you can go talk to when things get a little bit sticky, so that you can share and talk about what's happening with you. That's a key piece of starting to deal with secondary traumatic stress, is that you have the capacity to be able to talk with someone about what's going on with you. And you will see more about that when we get to one of the antidotes of how you resolve this. So now we're going to move from secondary traumatic stress into burnout. Now, I'm not sure, Marla, if people can actually respond to this, but I'd like to know, ask your folks a couple of questions, and maybe they can put it in the chat if they can't speak.
Sure, yeah, they can go ahead and put it in the chat. And I can, if
Okay.
you'd like, I can read out some responses.
Okay, great. So, who is at risk for burn? How many of you know someone that's burnt out? And how do you know that the person's burnt out? What are the signs and symptoms that you look for?
People saying themselves that they know other people, uh, they say they don't care anymore, short-tempered, stopped caring, change in behavior, irritability, tired, hates job, crying, low compassion, negative, snappy, apathetic, looks tired, not behaving like
Mm-hmm.
themselves, complaining
And
constantly.
we're going to go with those in just a moment, but you're going to start to see an overlap. So some of the things that is symptomatic of burnout is also symptomatic of secondary traumatic stress. So you can see them and not recognize necessarily which one it is, but there are characteristic things, the way that you're going to really identify and make the distinction. Is the reaction that you're having because of the environment that you work in, or because of the people that you're working with, or the coworkers that you're interacting with? So secondary traumatic stress is relational in that it comes from your relationship with your clients and the relationship with your coworkers. Burnout is looking more at what's the environment that you're in. What is how are the people? What are the expectations of you from your supervisors, from the people at work? And it's a slightly different. It's not that it's a different symptoms necessarily, but the cause of the symptoms have shifted a little bit from your clients to the actual work environment. So a lot of times people will describe it as a toxic work environment. So if you're in what you describe as a toxic work environment and you're experiencing these symptoms, it's more likely that you're suffering from burnout than from secondary traumatic stress. So what do we talk? What do we mean when we say burnout? Let's take a look at some definitions. Burnout is a psychological syndrome of emotional exhaustion, depersonalization, and depersonalization basically means like you're watching life as if it's a movie. You're not participating. Things you're going through your day, and you're going through your day as if you're an observer of yourself going through the day, rather than you actually participating in the day. So that's depersonalization, and a sense of reduced personal accomplishment. I heard you say that some of the people said that they don't care anymore. You get to the place of where, you know what, I'm going to work. I'm not getting any satisfaction from work. It's more draining than not. So all of these kinds of things lead to the syndrome of burnout: exhaustion emotionally, depersonalization, and a reduced sense of accomplishment. And that comes from Maslow and Goldberg in '98 and 2003, and then also Lubaday in 2020, basically used the same description to talk about burnout. Dr. Gentry, who is the developer of forward-facing professional resilience, and one of his colleagues, Anna Baranowski, who's up in Canada, as well as I forget Mr. Dietz's first name, but he's an MD that works in emergency room. He's a director of emergency services for a large conglomerate on the West Coast. As a result of their work, they came up with this definition, which is very simple, and I kind of like it. It's the chronic condition of perceived demands outweighing perceived resources. So in Dr. Deet's talking about this, let me just share this with you. He talks about being in the emergency room and patients just keep coming and patients keep coming. And so the demand is you need to move this patient from the emergency room into triage and into a stable medical environment within a certain amount of time. And it doesn't matter that you don't have any more room as the people keep coming in. You now get to the place of, wait a minute, I just don't have the resources, either physically or personally anymore, to continue to deal with the demand of the people coming in. So in the situation of working with people in different environments, like in a health center or even in your office, that you have so many clients and the clients are making so many demands on you that you look inward and you say, you know what, I don't have the resources to continue to work at this level. And so you start to move into this place of burnout. I cannot continue to do this, not because you don't want to. In fact, 99% of the time, the people who I'm talking to who will be likely to be on this webinar are the kind of individuals who are going to say, I'm just going to keep going because what I'm doing is important, the people need me, all of the things that you tell yourself about why you can't stop is what causes you to go into the place of burnout. You get, and you're going to have to start to look at how do you adjust your mindset so that that's not continuing, and you're not continuing to start to do damage to yourself. So here are some of the symptoms of burnout. There are behavioral systems. You withdraw from responsibility or social interactions, reduce performance or productivity, procrastination or difficulty concentrating, increased use of substances such as alcohol, drugs, or caffeine, avoiding work or necessary tasks, increased absenteeism on the job. Physical symptoms, chronic fatigue or exhaustion, frequent headaches or muscle pain, sleep disturbance, lowered immunity system. This is going to be important when we get a little bit later on. Remember this phrase. Actually, let me share it now. Disease or sickness does not come because of the thing that's introduced into your body. It comes because the immune system that's supposed to deal with that issue is not effective. So if you have low frequency of your immune system in any particular area, if you're not doing the things that's keeping your immune system active and vital, when things come in that the system has to fight off, it can't. And that's why you get sick, because your immune system is not effectively dealing with the challenges that it needs to deal with. So lower immune system deficiencies, changes in appetite or weight, gastrointestinal issues, and now we come to emotional symptoms, feeling overwhelmed or emotionally drained, increased irritability or frustration, decreased motivation or enthusiasm, feeling of cynicism or detachment, sense of helplessness or failure, increased feeling of anxiety or depression. These are the things that you want to start to pay attention to start to see if you have burnout. And as I said, some of these symptoms overlap with the ones that I shared with you for secondary traumatic stress. So the question becomes paying attention to what's causing it. Is it the actual dealing with the people or is it a function of the environment? So here's how burnout works. You have an increase in perceived demands and your perceived resources are not there. So what then happens, and this is critical, your nervous system does not know the difference between what's real and what's not real. As long as you perceive it, the nervous system is going to react. So if you have this situation, your nervous system perceives a threat. Your autonomic nervous system is going to pick up that something is off. And anytime you have a sense of perception of threat, your threat response becomes activated. And the threat response, if it stays activated, nothing happens to stop it from running wild. Actually, let me back up a moment. Everybody, every human being has to have an active autonomic nervous system. So having there be a activation of your sympathetic nervous system is not bad. You couldn't live without it. The problem is it's not supposed to stay on. So your sympathetic nervous system becomes activated because there's a perceived threat in the environment. So you get an increase in adrenaline, you get an increase in cortisol, you get an increase of all of the hormones that you're getting ready for fight, flight, or freeze. As you get ready for fight, flight, or freeze, signals are going to different parts of the brain now. Because that signal for your threat response goes down into your amygdala and your safety response network in the brain. While that thing is getting ready to protect you from this perception of threat, at the same time, another signal went to a different part of the brain that's saying, oh, there's nothing really wrong here. Because the signal that came into the safety and the safety network went directly from your senses to that part of the brain. There's another signal that goes up and goes through your cognitive functioning and actually processes and says, you know what, there's nothing wrong, you can relax. And your sympathetic nervous system will come back down to rest. If that does not happen, then you continue to be in this threat response. Your sympathetic nervous system stays on, and that's not good. That's a bad thing for human beings. Once you have processed whether this thing is a threat or not, you take appropriate action. If it's a real threat, you get the hell out of Dodge. If it's not a real threat, then there's a feedback mechanism that says to the brain, okay, shut down the parts that's producing all these extra hormones and these things that's causing this individual to be anxious. And that thing gets shut off. And so all day long, your brain is mediating between perceived threat and safety, perceived threat and safety. If that system does not work well, and you stay in a sympathetic dominant body, then you're going to be at risk of shortening your lifespan, of ending up with all kinds of physiological and emotional distresses. You go back and you look at those symptoms that we talked about, those symptoms will stay present. And you will be in a state of nervous system sympathetic dominance, which is not where human beings are supposed to live. You're supposed to be living in a parasympathetic body of rest and relax, or rest and digest. Okay? Quickly, let's look at this bottom piece here. So you have a perceived threat, and your body gets ready for fight, flight, or freeze. There is another one that's not often used, and I'm going to share with you, and it's the fawn response. The fawn response is really interesting. You're at work, and you notice your supervisor cussing out or reaming out or doing something to one of your coworkers, and you look at that and you say, I'm not letting them do that to me. So what do you then do? Your nervous system and your perceived threat response says, let me, an unflattering way of talking about this is you're sucking up. You start sucking up to the boss not because you like him, but because there's no way I'm letting him do what he did to that coworker to me. So whatever I need to do to prevent that from happening, I'm going to smoosh him or her until the point where it's not likely to happen to me. That's a threat response as well. So flight, freeze, and fawn are all part of the stress response. So this is what can happen either because of emotional, physical, or behavioral things that's going on around you. From burnout to resolution and resilience. The way that you move in these things is from self-regulation to relaxation to perceptual change and maturation. So let me talk a little bit about this. I mentioned self-regulation a few times. Self-regulation can be relaxing, but it is not relaxation. And let me make the distinction. Relaxation requires me to carve out some time out of my day to go off somewhere and practice whatever it is that I do. I do systemic desensitization, I do yoga, I do mindfulness meditation, I do guided imagery. Whatever it is that you do that helps you to relax, relaxation requires separating yourself from your ongoing daily activities. Whereas self-regulation requires you to be able to bring your body and your nervous system under control while still engaged with the thing that's caused you to be activated. So if I'm having an argument with a coworker, self-regulation is I'm able to prevent myself from going on emotional overload and my nervous system getting so jacked up that I can't maintain my composure while I'm still facing that individual. And one of the things that we do in the forward-facing resilience is to talk to you and give you some skills for how to deal with self-regulation rather than relaxation per se. And obviously, because of the time, I don't have time to go into all of it, but I will be giving you in the next few minutes the distinction of what we do in terms of the skills that we teach in the workshop. Okay, so I talked to you about the problem. Resilience is the solution. So now we're moving into, so how do you stop yourself from going into compassion fatigue, or what are the things that you do to come out of it once you're there? So let's now look at what is forward-facing. So forward-facing was developed as a way to treat trauma in the present without revisiting painful memories. It's expanded to become a simple method of resolving stress-related issues while simultaneously optimizing our lives. And so in short, forward-facing is taking self-regulation, pairing it with intentionality. And you do those things and you're now in a forward-facing approach. Very briefly, I'm old enough to remember when veterans were coming back from the Vietnam War and mental health professionals were starting to try to figure out, okay, how are we going to work with these individuals? And back then, they used to do something called implosion therapy, which basically meant that the veterans were coming to the therapist's office, and every time they came to the office, the therapist would ask them to go back and dig up that painful memory that they're trying to get past and say to that person, let's dig up this memory and look at it and see if we can process you through it. And over time, if they stayed with it, they actually became desensitized to that. But more often than not, those young men basically voted with their feet. They stopped coming to therapy. And you talk to them to say, you know what, I would rather live with the pain of that thing than have you come in here every week and have me dig it up and go over. I'd rather just let it stay, and when it comes up, I deal with it. So what forward-facing does is says, listen, we're not going to talk about your painful past issues unless it's bothering you right now. If it's bothering you right now, then we work with it, we process through it. But basically, our intention is we're going to start to have you look at how do you move forward with your life and optimize the things that you want out of life. So that's the forward-facing approach. And there are 5 things that we put into addressing compassion fatigue and forward-facing. The first one is self-regulation. That's the ability to immediately shift from sympathetic to parasympathetic dominance. The ventral vagal complex, those of you who are familiar with Stephen Porges' polyvagal theory, especially when there's a perceived threat. So being able to shift from sympathetic to parasympathetic in the face of a perceived threat. Intentionality is principle-based versus demand-based living. That is, you craft a statement of who is it that you want to be? What is your intention for your life? And then once you look at that intention, are you living according to the things that you say you want to do? Perceptual maturity is evolving the perception of yourself and your context to detoxify the workplace. So right now you have a particular way of how you look at things at the workplace, the demands that's placed on you. And what we begin to push you to do is to shift your focus from an external to an internal locus of control. As much as I want to make demands of you, you have the right and the capacity to choose which of those demands you're going to address in what order. And at work, there should be the capacity for you to say to the individuals that's putting all these demands on you, so you've given me all of these things to do. Is there a priority that you want them done in? Or do I get to make my own priority? So those kinds of conversations will start to take place as you start to develop perceptual maturity. Then you have to have connection and support. You've got to develop and utilize a support network. You have to have self-care and revitalization, refueling and sustainability. You have to do things that's going to recharge your battery. So those are the 5 elements that's built into the forward-facing professional resilience workshop, and we go into it in a lot more detail. One of the very things that we ask you at the very beginning of the workshop is your life stressful, or is your job stressful? And then we go through what are the causes of the stress and what are some of the effects of the stress. And we do it in reverse. So we want to know what does stress, the effect that stress has on you, and then we say, okay, so what do you think is the cause of those effects? And we do that very early in the workshop as a way of getting you prepped to understand where you're going to be headed. So let's take a quick look at this. Stress and reactivity. So stress, simply put, is your physiological reaction to an event that's occurring in your life. So once this thing is happening, you then have a nervous system response. So stress is a neurological phenomenon. It is your neurology, it is your nervous system reacting to the things that's happening around you. And once you have that activation, that's stress. And then the question is, so how do you know that you're stressed? Anytime you're stressed, you have involuntarily constricted muscles in your body. So anytime you check in with your body and you are not purposely tightening the muscles in your body, there is some form of perceived threat in your environment, either presently or that you're carrying with you. And if your muscles are constricted, there is perceived threat. What that does is it adds energy to your nervous system, adds energy to your body, and you're going up. And as the energy in your nervous system is going up, your neocortical activities are going down. Dan Siegel has a model where he talks about the hand model, some of you may have seen, where he talks about this being your brainstem, this is your limbic system where emotions lie, and this is your cortex that has your executive functions in it. So what's happening here is if you do not do anything to stop this energy from rising up, talks about you flip your lid. And when you flip your lid, that basically means that you do not have access to the rational part of your brain. You're now being fueled and managed by your autonomic nervous system, your threat response system, the amygdala, and all of those parts in the subcortical parts of your brain, and your limbic system. They pair up and they're energizing you. And as it continues to go up, you get to the point to where there's a threshold. And when you hit that threshold, you no longer have access to being a reasonable human being. You're now responding out of the place of your sympathetic, you're now reacting from your amygdala and your emotions, and it shut down your ability to think reasonably. What then happens? You are compelled to act either compulsively or aggressively in order to deal with the situation, and you now have a breach of your integrity, and you are no longer being the person that you said you want to be in your intentionality, in the documents that we create. So another way of thinking about this is this way. This is the Yerkes-Dodson law curve. It's a human function curve that's been around for over 100 years. When you get up in the morning, when you start off at zero, there is no arousal and there is no performance. So you are at rest. As you go through the day, your arousal increases, your performance increases, and you continue to go up and up until you get in the comfort zone. If you're able to stay here, you could pretty much work all day long and not feel fatigued. But as the stress continues, or as the arousal continues, the performance continues to go up until you hit the hump. When you hit the hump, now you're starting to come down and you're becoming more and more exhausted. And if you stay in that state, you come all the way down here to where you have a breakdown. Now let's take a quick look at this. Over here, it talks about good stress, but it's not just necessarily good stress. What you have here is there are no symptoms. There are no symptoms associated with burnout or secondary traumatic stress when you're on this side of the Yerkes-Dodson curve. As you go over the hump, now you're symptomatic. Now you're starting to experience pain. You're starting to experience suffering because of what you're doing. And you're eventually going to go into this place of dorsal vagal shutdown, where in polyvagal terms, it's a collapse. Okay. So, resilience skill number one, self-regulation. Self-regulation, as I said before, is being able to bring your body, let me go back up here. Self-regulation is being able to bring your nervous system from this side of the Yerkes-Dodson curve back over to this side. You don't have to come all the way back down here, but you have to get past this place to where you're still symptomatic and the things that you're doing is causing you distress. So that's self-regulation. To talk about it again from the perspective of Stephen Porges' polyvagal theory. Polyvagal theory gave us a term that was not being used before, and that's neuroception. Neuroception talks about being able to detect whether things are safe or not safe by using your five senses. If you can process your five senses and say, okay, there's nothing here that's dangerous to me, then you're being in the present. You're able to deal with what's happening right now, right here, and that's a neuroceptive perspective of safety. What has been around for a while is this idea of interoception. Interoception is your capacity to feel safe and to log into what's happening in your body in the moment, right now. If you're able to peer neuroception and knowing what's happening in your body right now, and you add relaxation to that, you're able to self-regulate. And again, self-regulation is what keeps you from developing secondary traumatic stress and burnout. So the first thing that we want to teach you is self-regulation in the workshop. Now, interoception, Bessel van der Kolk, if anybody's in the trauma arena, they know who this gentleman is. He's one of the world-renowned experts on stress and trauma. He says, you know what heals trauma? Interoception. It's the present, it's the felt sense of your own physiological processes, becoming sensitive to feedback from your body, lowering the threshold of awareness of dysregulation. In other words, you're noticing much more quickly when you're starting to become activated. Monitoring rising levels of energy. So you're paying attention to your sympathetic nervous system, recognizing when there's a need for conscious and intentional intervention. So it's releasing the constricted muscles. People who are highly traumatized have an extremely hard time doing this. They can tell you, or you can get them to do the neuroception piece because they can check around and say, okay, nothing's going on. But for them to feel safe in their body is extremely difficult to do. So they will tell you, yes, I know that there's no danger. I can't see anything that's dangerous, but I still do not feel safe. So it's a thing of checking in, being able to notice your own body on a regular basis, noticing what's happening with it, and respond to that in real time. Lots of people have a difficult time doing that. I confess to being one of them. I'm learning. Okay. The next antibody or the next skill is intentionality. Do I go where I point myself? Living or working in accordance with your mission, your covenant, your code of honor and vision, which I'm going to talk about in a minute. It requires self-regulation. It requires an internal locus of control, and it requires principle-based living. When we do the workshop, we have people do these things. You develop 3 documents. The covenant is, when I'm being the best human being that I know how to be, what does that look like? And let's get that in writing. Your code of honor, what are the principles by which you live? And your vision is, if you're following your covenant and your code of honor, what do you expect the outcome to be? So we give you time to write those things. We give you opportunities to do that. And then we discuss those. If I'm doing it individually, we do it session to session. If I'm doing it as a workshop, we create time in the workshop to do this. And individually, not in the workshop, but when we do an individual, I take the client reading these documents. And then I give them the video and say, now, here's what I want you to do. I want you to go home and watch this video and watch it with caring and self-compassion. Providers, by and large, are more compassionate and caring for others than they are for themselves. So I make sure I tell you, when you're doing this, imagine that you are the client and you're going to show some self-care and compassion for yourself. Now, how do triggers work? You're going along here, you have your covenant, and your covenant says, I want to be loving, trusting, honorable, and have integrity. Now you're moving along and your 5 senses are at work and you see something that triggers you. You do not continue on this path of intentionality. You instead become reactive. You become impatient, snarky, resentful, and withdrawn. And at the very same time, your mind goes back to the painful past learning that reminds you of this situation. Remember, we talked about traumagenesis. Your mind takes you back to this conditioned response of the painful past learning experiences that you've had, and it completely ignores all of this stuff that you want to do, and it takes you up here to being reactive. The way that you get around that is you interrupt the threat response and heal the moral wound in this way. You have your covenant, you are triggered. Oops, sorry about that. This thing got disrupted. You are triggered, and instead of you going up here, there is no place up here for you to go off and be reactive. You're staying because what you do is you put in the relaxed muscle in here, and your intentionality stays with you and continue to be the person that you want to be. The third resilience skill is perceptual maturation. Change the way you look at things, and the things you look at change. So you will start to pay attention to different things at work because you're starting to reframe what are you looking at and how am I taking control of what I do rather than letting the situation keep control of me. Perceptual maturation, internal versus external locus of control. You start to deal with real versus perceived threats. You start to look at demand versus your capacity to choose. You start to look at whether you're outcome driven or whether you're driven by your personal best practices. Acceptance of anxiety. There's a thing called ontological anxiety, which means that anxiety exists just because you're alive. And so anxiety is going to be a part of your existence. You just have to start to look at, so what are the things that you're being anxious about that you do not need to be? And then you start to talk about your intention, purpose, and meaning of your life as you begin to change your perceptual maturation. Lastly, the last resilience skill is connection and support. You have to have your peeps around you. You create a sanctuary of community, ability to safely tell on yourself, licensing others to confront your symptoms. The opportunity to narrate secondary traumatic stress experiences is key. Resolving attachment trauma, responsibility to train your support group. So just because a person is part of your peeps, they don't necessarily know what support looks like for you. So you want to start to tell people, this is what's supportive for me when you notice X, Y, Z. And lastly, the last resilience skill is self-care and revitalization. If you look up any place on the net, you can find some things about what to do for self-care and revitalization. There's physical self-care, there's emotional and mental self-care. My mouse got stuck. Social self-care, lifestyle adjustments. All of these things are about taking better care of yourself. Revitalization strategies. You want to do hobbies and creative outlets. You want to have goal setting, and you want to have self-compassion. All of these things we cover in the workshop so that you have an opportunity when it's done to be able to start to process and live a life of purpose, on purpose, rather than reacting to what's happening around you and letting your nervous system and your dysregulation control your life. If you want further information, you can reach me at any of these things, my phone number, email, or by going to the website. Thank you for listening. I had hoped to leave a little bit more time for questions, but we got bogged down at the beginning. Okay, Mala.
All right, thanks so much. We did have one person ask, I missed whenever it happens, whenever it came in, do we categorize people-pleasing behavior as a fawning response?
It depends on the motivation. If your motivation is to prevent them from doing something bad to you, then yes, it's a fawning response. If you're doing that because of some other motivation, it's not necessarily the case. You got to look at why are you people pleasing? I'm people pleasing because I don't want these folks to be mad at me, and because when people get mad at me, I remember when my dad used to be upset with me, and so yes, in that kind of situation, yes, it's a fawning response.
All right, thank you so much. And lots of people just saying how what a good webinar this was. I know I learned a lot. So thank you so much, Dr. White. I apologize for the technical difficulties at the beginning, but I'm glad we were able to make it work.
Yes.
Now if folks want to stick around for a few minutes, I'm just going to go over some last minute housekeeping. Thank you for taking time out of your day to attend. We would like to remind everyone that a PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IRETA's website sometime within the next week. I now want to remind you of our evaluation and CEU process. You will receive an email after the webinar concludes. This will include a link to our evaluation and step-by-step instructions on how to obtain CEUs. Please note it will take up to 48 hours for your CEUs to become available because of our need to cross-check your attendance records with WebEx. We would like to request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, thank you to everyone for taking time out of your day to participate, and thank you again to Dr. White. If you have any questions, please email us. The email address is info@ireta.org. And with that, I will conclude today's webinar. Thanks so much, everyone.